Noswaith a chroeso. Mae'n hyfryd I bod nôl yma ers 3 blynedd. Good evening and welcome everyone. It's wonderful to be back here in person, first time in 3 years. So I can think of no better person to initiate this year's lecture series than Professor Peter Elwood. So Professor Elwood qualified in medicine at Queen's University, Belfast in 1954. After a few years of clinical practice, Peter became a member of the scientific staff of the MRC Epidemiological Research Unit, South Wales, in 1963, and followed on from Professor Archie Cochrane as its director from 1974 until its closure in 1995. At that time, Peter was told he must retire, but he ignored this instruction and has continued to work ever since, the work being too fulfilling and occasionally too important to leave. For over 50 years, Peter's research has been on the prevention of disease in one form or another. In addition to his world-leading and pioneering work on aspirin, more of which this evening, in 1979, Peter set up the Caerphilly cohort study that has followed 2,500 subjects for almost 40 years. Results from the Caerphilly study have led Peter to advocate a healthy lifestyle. Peter, you're certainly a living advertisement for that instruction. Peter is currently Honorary Professor at the Institute of Primary Care and Public Health, University of Cardiff. So a huge welcome to you this evening, Peter. Thank you very much indeed.
Thank you. Nice. Well, thank you very much indeed for that welcome. And I must say it's a tremendous pleasure and a tremendous privilege to be able to talk to you. I'm going to condense 12 or 13 years of intensive work into a 45-minute. I'd probably go on to an hour or two, but I've got to leave out a lot of the fine detail. But I'd like to start by attributing, paying tribute to the workers with me. The immediate team I have is that's not bright enough either. The team are in bold, and my best gift is delegation. And I am very quick to delegate to an expert some aspect of the work which I'll be presenting. And of course, I just do the talking when it's all put together. The colleagues down at the bottom are colleagues who were co-authors on the various papers. And I just add them there to show that it's not just the opinion of one elderly epidemiologist that I'm putting to you, but a high level of collaboration across countries, across disciplines are behind this talk. Now, the background, the structure of my talk is I'd like to tell you how I got into aspirin, and then I'd like to concentrate on the safety of aspirin, which has come under question, and aspirin as an additional treatment of cancer. And then the most difficult question of all, who should evaluate this evidence? I think I'm going to put to you evidence which is very powerful. I think you'll be surprised at the extent of the evidence that I'm going to put before you. And so I'm going to dwell at the end on this issue. Who should evaluate the evidence? Now, when I came to Cardiff way back in 1963, I learnt of some work that was going on in Devil Hall Hospital. What's happened? Next. What do I do? Work was going on in Neville Hall Hospital, and I got to know these two men and made friends of them. their work commenced way back in 1954. And they had published a series of articles in top journals on aspirin and heart attacks, or as it was called then, infarctoid cardiomyopathy. The trouble in their work was they were using huge doses of aspirin. Some of the patients were given 10 full-scale 300 milligram aspirin tablets 4 times a day, and the patients just couldn't tolerate it. And so eventually they gave up that treatment and went on to other things. But I heard of this work, and I thought, well, I looked at some of their papers, and Archie Cochrane and I felt that there was mileage in that topic, in that hypothesis. And so we set up a randomized controlled trial of aspirin in the secondary prevention of mortality from myocardial infarction. We enlisted 1,400 men who'd had a heart attack, and we put half selected at random onto aspirin and the other half onto a dummy placebo tablet. That showed a 24% reduction in myocardial infarction and death from heart attacks. And it went viral. And for the next 20 years, I traveled the world at intervals, presenting that paper and other papers which were subsequently published on aspirin and heart attacks and stroke. It was shown shortly after that paper. But I thought that there's something very special about this aspirin. It's a very simple molecule. And it goes back to herbal medicine. A lot of the plants used in herbal medicine have high levels of salicylic acid. And aspirin itself is made simply by taking salicylic acid and adding a bit of vinegar, and you get a white powder, which was called aspirin. And so I made inquiries about the plant world. Who is the expert on salicylic acid within the plant world? And I was told that a man in one of the agricultural research units, Stan Pierpoint, was the world authority on salicylic acid. So I went to see him. He was a dear old man, and he spent a few hours talking to me with enthusiasm about salicylic acid and its effects in plants. It's very, very active in plants. And I had a delightful meeting with him and a lot of encouragement. And I told him about the trial we were setting up in heart disease. So as I was leaving, he turned to me, and his final word of advice was, "Peter, skip heart disease and go for cancer." Well, I had to explain to him that we had enough resources to do a study, and our study eventually had 1,400 patients in it. I told him if it was cancer, we'd need at least 4 times that size and probably 4 or 5 times the duration of the trial. I just didn't have the resources to do that. But 25 years later, opportunity arose for work on aspirin and cancer, and there was growing interest from a number of sources. And so my little team decided that we would work on that. And we put together all the available evidence at that time. We wrote a review of aspirin salicylates and cancer, and The Lancet published that. And that was very, very widely quoted. So that's how I got into aspirin. Originally in 1974, our first publication, but aspirin and cancer dates from 2009, whatever that is, 13 years ago. So the main part of my talk will be on the safety of aspirin and the effect of aspirin as an additional treatment of cancer. Now, before I present any clinical evidence, let me just make 3 principles about research. First of all, my boss in my early years in Cardiff, Archie Cochrane of this university, he very effectively publicized the principle that in evaluating evidence, it's essential that all available evidence is considered and never just a selection. It's awfully easy to have a hypothesis and spend a Friday afternoon going through the literature and finding one or two publications that show the same kind of thing as we're looking for in that particular hypothesis. That is so misleading, it should never be done. So he went to enormous efforts, as you will see in what follows, that we would collect all the available evidence. Then the father of modern medicine, Sir William Osler, he said, and I think it sums up medicine, medicine is a science of uncertainty and an art of probability. In the end, science never proves anything. There's always another explanation, and conclusions about a particular hypothesis can only be established at best to be beyond reasonable doubt. But don't look to me for any certainty in what I say, but I think we've established a number of important steps which go beyond reasonable doubt. Now, the safety of aspirin, the safety of any drug or in clinical intervention is usually judged from its risk-benefit balance. Now, the benefits that I'm going to present to you are almost entirely the reduction in the number of cancer deaths in people taking aspirin. But aspirin has other effects. And going back to 1968, there's a huge literature on a reduction by aspirin in metastatic cancer spread. Many of the deaths and much of the pain and distress of cancer comes from the spread of cancer from the original lesion to other organs and other parts of the body. So there's a huge literature on that, which I'm not going to take time to put to you. And there's also an important chance of vascular complications occurring in cancer. Something like 10% of the deaths of patients with cancer are allotted to vascular disease, heart attack or stroke, or something like that. Aspirin has already been shown by countless randomized controlled trials to reduce the risk of vascular complications. So already we have good evidence on that. Metastatic cancer, take my word for it, that there are lots of papers showing that. But I'm going to focus on the number of cancer deaths. Now, against those benefits, the major risks in assessing the value of aspirin in clinical practice is the increase in the number of stomach bleeds. Now, the stomach bleeds due to aspirin are an increase. The stomach bleeds occur in the community quite apart from aspirin, remember that. And aspirin increases that risk by a small number. And very rarely, a very serious bleed is into the brain. So let's look at the evidence on that. Now, my colleague, Gareth Morgan, my closest colleague in all this work, pointed out that in the risk-benefit balance, as it's usually done, is simply the number of stomach bleeds is evaluated against the risk-benefit balance in the reduction of the cancer deaths. Now, that is unbalanced. Most of the stomach bleeds are trivial. Very, very few bleeds are serious, really serious. Very few cause death. But men, when they're shaving, may say, well, I'm on aspirin and it's bleeding a bit. So the number of stomach bleeds is grossly overloaded by trivial and by minor bleeds. So we decided, as our first study, that we would conduct an extensive study into bleeding attributable to aspirin with a focus on severity. And we decided to focus on the most serious bleeds, that is, fatal bleeds. So we set up a systematic literature search. Now, at this point, I would like to pay tribute to the library in Cardiff University. Two of the ladies there, Alison and Delith, put an enormous amount of work into doing systematic literature searches, trawling through all of the medical publications over the years, using keywords to pick out reports which might be of relevance And then two of us, Gareth and myself, going through the abstract, reading the abstract of every single paper, thousands of papers, looking for studies which would fulfill the test, the aims of our study. Well, we found 100,000 patients had been randomized to take aspirin or to take placebo in 11 reports, and we put those 11 reports together. So none of this was a Friday afternoon study. It took us about 3 years to do this study and to put together all these reports. And the results were of considerable interest. Over the 3 years, the number of stomach bleeds in these 50,000 patients was 8 per 1,000 in those on aspirin, 5 per 1,000 in those randomized not to take aspirin, but to take a dummy tablet. Now, there's a small excess there in those on aspirin, but remember that the patients randomized to placebo in the community, stomach bleeds occur, usually due to a peptic ulceration, an ulcer in the stomach or the duodenum, or an infection with Helicobacter pylori, an unusual infection which can cause bleeding. So it's a very reasonable assumption that the patients randomized to aspirin also had bleeds due to an ulcer or due to an infection. And so probably 5 of those 8 bleeds were due to pathology in the stomach, and only 3 were attributable to aspirin. That's a very reasonable conclusion from those 2 figures. So we then went on and looked at the fatal bleeds. Here's the proportion of bleeds that were fatal in those 50,000 patients. In patients randomized to placebo, the ulcers and the infection caused about 8% were serious enough to cause death. In aspirin, the proportion of bleeds is half of that, is only 4%. Now, what's going on? Well, there were more bleeds. There were 8 bleeds, after all, in 1,000 patients than those on aspirin, and only 5 in those on patients. So evidently, the bleeds which were due, which were attributable, rightly attributable to pathology in the stomach, were diluted by further bleeds due to aspirin, and those bleeds were not as serious, and they were not causing any excess fatal bleeds. So the bottom line in that study is that the risk of a fatal bleed is the same in patients who are randomized to aspirin and those who are randomized to placebo. In other words, aspirin does increase the number of bleeds, but not the serious bleeds, and certainly not fatal bleeds. Now, one of you will no doubt raise the question, but what about all the claims on the web and elsewhere about aspirin and fatal bleeds? There are very frequent claims that aspirin causes extra bleeds, some of which are fatal. Well, I can tell you, we have looked at countless of those claims on the web, and in our published papers, we deal with some of the most extravagant claims about fatal bleeds, and we argue that they are false news, they're fake news, they're counterproductive compared to all the other work that's been done on bleeding attributable to aspirin. So I'm not going to take time to look at those now, just take it from me and look up our papers. Can I say at this point that all the papers that I'm going to present to you have been published in open access journals. We are very anxious to get this information to patients and to the ordinary doctors caring for those patients. And so we have published everything of ours in this area. We have published in open access journals. So I won't go on any further with that, but also to point out that we're not alone in this. Our search of the literature showed that there were 5 other studies in which a number of randomized trials have been put together. The ATT, the aspirin antithrombosis trialists study, a very fine study in the BMJ. that shows a very closely similar result to what we found, that the risk in those on aspirin is half the risk in those not taking aspirin. And so out of those 5, well, there is one that we would assume on chance. It'd be strange if there wasn't one that showed a risk, because chance is playing a great part in all of this kind of work. But the overall evidence is that the risks of a bleed from aspirin is of a minor bleed and not a very serious bleed, and certainly not a fatal bleed. But there are, of course, there is another publication, very recent publication, which some of you will know of, and that's the Aspirin trial in Australia, a huge trial with 14,000 subjects. And last year, the first preliminary publication, two publications on Aspirin were published. And there were 2 fatal bleeds in that trial, and both those bleeds were on patients who had been randomized to receive a placebo and not aspirin. So, of course, there is another bleed, and that is intracerebral bleed or hemorrhagic stroke. And that's a rare but a most serious event in patients on aspirin. But again, hemorrhagic strokes occur in the community, and hypertension, or raised blood pressure, is the factor most powerfully predictive of a cerebral bleed. So there is a randomized controlled trial, not ours, a randomized controlled trial of 20,000 patients, all with blood pressure, raised blood pressure, and these were all on optimal antihypertensive treatment. And in 10,000 patients on aspirin, there were 7 fatal bleeds. Amongst 10,000 randomized not to receive aspirin, there were 8 fatal bleeds. So I think we can summarize all of that in these terms. A bleed is a crisis, and especially in a patient who's already ill, who already has cancer or has had a recent heart attack. A bleed is a crisis. And the bleeds require urgent treatment. But bleeds attributable to aspirin appear to be less severe than spontaneous bleeds due to stomach ulcer or infection. And bleeds attributable to aspirin are less serious than the spontaneous bleeds that occur in the community and are seldom, if ever, fatal. Now, the trouble is that if an aunt of yours or an uncle or someone like that has a stomach bleed, the first question the doctor will ask, and the first question will come into your mind, are you on aspirin? It's the aspirin. But no, the greater chance is that it's from pathology in the stomach, and there's only a smaller chance that it is due to aspirin. And if it is due to aspirin, then it's very unlikely to be a fatal bleed. So let's go on now to the other big question. What is the effect of aspirin taken by patients with cancer? Now, the first item there is aspirin and biological mechanisms. How does aspirin work? What are the mechanisms affected by aspirin, and how do those have an effect on the progress or the mortality of cancer? Well, again, I'm going to plead your indulgence, because just last month, we published our latest paper on biological mechanisms and clinical outcomes. And together with Madge Proti, who's a highly expert on biological mechanisms, that is, mechanisms within every cell of your body and within the bloodstream in your body, he is the expert on biological mechanisms. And we worked together on this, and we showed that there's a remarkable harmony between the effect of aspirin on biological mechanisms and aspirin and clinical outcomes. And we, in our paper, talk about the harmony, the expectation which is generated by the vast amount of work that's been done on the biological mechanism of aspirin. So let me just quote from our paper in September. Here is Madge Proti's summary. The effects of aspirin upon biological mechanisms involved.
Attention everyone, the Centre for Student Life will be closing at 8 p.m.
Not a chance. Don't tell them. The effects of aspirin upon biological mechanisms involved in the development and growth of cancer appear to generate reasonable expectations of effects upon the progress and mortality of cancer. And let me pick out one mechanism, DNA repair. This is a remarkable mechanism in every cell in our body. When cells divide, and they're dividing all the time, errors can occur in copies of the DNA, and these can lead to cancer, and that can occur in any of us. Aspirin enhances the mechanisms which detect and repair DNA errors, and aspirin therefore appears to be a protective measure in all of us. Now, sadly, there is a syndrome, the Lynch syndrome, and in this, people with this syndrome develop a cancer, usually before the age of 40, and it's usually a very malignant cancer, usually colon, but other cancers can occur. And this is due to a mutation which inactivates the DNA mismatch repair. Now, I find it fascinating that NICE has accepted evidence on the benefit of aspirin, on that mechanism, and on the clinical cancers in these patients. And NICE is already recommending aspirin as a treatment of colon cancer, granted in only a small proportion, but not that small. It's estimated by Burns of Newcastle, who did all this background work, it's estimated that there are about 30,000 unknown carriers of the Lynch syndrome in the community who would benefit substantially if they were told about the benefit of aspirin, if they could be identified and told of the benefit of aspirin. So what's the evidence on the benefit if aspirin is used as an additional treatment of cancer? Now, most of the evidence I'm going to put to you is actually from observational studies, and these have limitations. In observational studies, patients with cancer are followed forward in time, and their clinical experience and mortality is compared in those taking aspirin and those not taking aspirin, and the clinical experience of the two are compared. Now, the trouble in this design of study is that the patients on aspirin tend to be older, tend to have more disease, and they're not matched with control patients. They're just the real-life situation in the population. And there can also be publication bias. If one does a study and it doesn't fulfill expectations, well, there's a chance the report will go in the bin rather than be published. So we've got to keep all that in mind. But again, the girls in the library, Alison and Delith, spent days doing literature searches. We did a literature search and published it in 2016. Now, one of the essentials in research is replication. And so we got a very encouraging answer from that study, but we felt, no, it could be chance. Let's do it again, and let's do it yet again. And altogether, we have evidence on around 1 million patients with cancer, and details of their death and cause of death, and details on their treatment. And about 25% of that 1 million patients reported at diagnosis that they were taking aspirin. So what's the evidence from that? Well, let me warn you, the evidence is large and complex, around 1 million patients. Different measures of mortality were used, and some reports record cancer mortality, and in others it's all-cause deaths. Let me put up a blank table. Here is the cancers on the left, altogether with 18 different cancers. Here are the cancer mortality data and the all-cause mortality data, because there's no point reducing cancer if the intervention, the drug or whatever, is causing other deaths which outweigh the benefit on cancer. So some of these papers focused on all-cause mortality. And there were two ratios, hazard ratio and odds ratio. And statisticians refuse to amalgamate those two because the methodology is different. But I'm going to, Janet Pickering and Christine Dillon did the work, but I'm just going to amalgamate them anyway. So here's the table that we actually published based on around 1 million patients. We did the literature search and we found eventually that there were 118 published observational reports. Now, Archie Cochrane would insist immediately that you go to the bottom line. The best evidence from a table like that is the bottom line. What is it overall? And then if you want, you can omit 1 or 2 cancers if you know of some mechanism that will make the aspirin inappropriate. But here I've just put the bottom line, all 18 cancers. And let me simplify that. Colon cancer. Cancer mortality, there are 25 studies and they show a 26% reduction in mortality and deaths in those on aspirin. All-cause mortality, 22 studies published data on all causes of death, and it's 20%. And again, look at the bottom line, which is the main conclusion of those data. About a 20% reduction in cancer deaths, and a 20% in deaths from all causes. Now that's further evidence that aspirin is certainly not causing any sizable number of deaths through bleeding. The reduction is virtually identical. Hazard ratio 0.79, hazard ratio 0.80. But the gem of that study is a further 2 studies. Colon cancer is the cancer that most of the research is done on. It's the most common cancer in men and women. And there have been 25 studies showing cancer mortality in people who have a colon cancer or colorectal cancer. We included less common cancers, and we identified 36 published reports on less common cancers. And there, the reduction is 20%, very closely similar, and it is statistically homogeneous, those 2 results. So this validates our original proposal that we would look at all cancer, and not just like most other research groups who look at colon cancer and occasionally breast or prostate cancer. We search the literature for all cancers. So another measure is the duration of additional survival. Is it just a few days, a few weeks, a month or 2? So we put together all the evidence we could find on additional survival in those on aspirin. Now this is bound to differ for different cancers. And again, there are difficulties arising from different measures of survival. Let me again put up a blank table. Here are the authors of the papers. There are not many of them compared to the earlier slides. Here are the different cancers, and naturally it's going to be different in a liver cancer or rectal cancer or head and neck cancer. Here are the measures, and you just cannot amalgamate the median overall survival in days with the 3-year overall survival. So we cannot amalgamate these, and they are selected. They're not all the papers gave this particular bit of evidence. But there are the data. And in every case, the survival is considerably longer in those taking aspirin compared to those not taking aspirin. Now let me just point out one dreadful error in my typing. The 3rd column there, no, it's not going to show. The 3rd column shows with aspirin 6.7.3. Well, that's an extra decimal point, and it is actually 6.7% had a 3-year survival, whereas in those not on aspirin, it was only 31% survived 3 years, a doubling. So sorry about that mistake. I only spotted, or my daughter-in-law spotted it last night, and I didn't have time to make a new slide. Now, one group used another approach to this, and they did modeling. We all may be quite suspicious of modeling studies after the disaster with COVID and the answers that were got from modeling studies. But a group in Liverpool used data from over 44,000 patients with colon cancer to derive a predictive equation which would relate a number of factors present at diagnosis of cancer to the duration of survival. And using that formula, we found that entering aspirin into the predictive formula increases the estimate of survival of colon cancer by about 5 years for a man and about 4 years for a woman. That's quite substantial and of tremendous value to patients. Now, there's doubt in any modeling study, but against the background of the other evidence that I presented, I think we can say it's beyond reasonable doubt. Now, these are observational studies, and there are limitations in observational studies. People who take aspirin differ from other patients in the group or the cohort or whatever group is being followed forward. Differences include the age distribution, gender, social class, and you can allow for these statistically, and that has been done throughout the data that I've presented. Then there are differences which include items like blood pressure, previous current diseases. These may not have been recorded. Where they were recorded, they're taken into account in the analysis. But then there's the query, are there other differences, some of which may not even have been thought of, let alone allowed for? So there are limitations in observational studies, and the number of studies doesn't get over the number of people in the studies, doesn't get over these difficulties. They're inherent in the strategy of observational studies. And there's also publication bias, which I've already mentioned. And hence the advantage of random allocation of a drug or other clinical intervention. Now, let's look at the randomized controlled trials. Randomized trials are simple and very easy to understand. They're based on, in cancer, it has to be a very large group of patients with cancer, half of whom, selected at random, are asked to take aspirin consistently, and the other half are given a placebo and told not to take aspirin. So it takes a very high level of collaboration to set up a valid and dependable randomized trial. But this ensures that factors other than aspirin taking are balanced between the two groups, the groups on aspirin and the groups not on aspirin. Now, these trials have to be very large, very long-term, very expensive, both in money and in labor. And one point I should mention here is that no commercial firm has a real interest in aspirin. It makes no money. So there's going to be very great difficulty in getting money for a large, long-term trial. And the pharmaceutical industry has no interest in a drug which makes no money. But the other thing, it's become apparent in recent publications that compliance with aspirin taking can be low. There is the Aspirin study in Australia, which I've already mentioned. There, over the period of 5 years, there was a 40% group of patients neglected taking the aspirin. They denied an interview, but tablet counts were done, and it was estimated 40% of the patients during that 5 years had stopped taking aspirin. There are several studies from Dublin, and those show that the Irish are good liars too, and the uptake of the aspirin fell by 40% in both colon cancer and in breast cancer studies of aspirin. Compliance is evidently a far bigger problem than or could be a bigger problem than we thought it was. So there have been very few randomized controlled trials. There were 4 very early trials, 9% reduction, only a hint of benefit. Then a better study in a large US study a large study in which aspirin had been randomized. 500 patients developed prostate cancer during the study, and those were followed up as a separate group, and they showed a 32% reduction in prostate cancer from the aspirin to which they'd been randomized. That's very powerful evidence. And around the turn of the century, Peter Rothwell in Oxford set up a long-term follow-up series of studies, follow-up up to 20 years, and these were based on subjects who had been involved, up to 51 studies who'd been involved in earlier randomized trials of aspirin and heart disease. And they followed these patients up and got causes of death and hospital admission. And they showed in every one of their studies, they got pictures like this, that the deaths from cancer in those on aspirin is the heavy line. The deaths in those not on aspirin, not originally randomized to aspirin, is considerably lower. I wish I had thought of that study, but it is not conclusive. There are other explanations, but it's certainly highly suggestive. And very recently, a randomized trial, just earlier this year, a randomized trial in 3,000 patients with a very advanced breast cancer and a particular type of cancer, the HR2 negative breast cancer. That trial had to be stopped prematurely. It was stopped after 20 months because of a significant excess of relapses, as the paper terms it, in patients on aspirin, with a 27% increase in the number of further breast cancer development or deaths in those on aspirin. Now, that's an unfortunate trial. We've got to put that into the equation for all of the evidence that I've been presenting. But one would just comment that that's a subgroup. He's obviously enjoying the talk.
Attention everyone, the Centre for Student Life will be closing at 8 p.m.
So that has to be put into the mix and has to be given appropriate weight against the evidence I've already produced. So there is the summary. The safety of aspirin seems to us to have been established beyond reasonable doubt. And in comparison with other drugs for cancer, it is a highly safe and well-tolerated drug. The effectiveness of aspirin treatment, there's no proof there, but the biological mechanisms predict the clinical studies, the clinical effects that I've presented to you. Most of the evidence is observational studies, but there are some randomized trials. So who should evaluate? Well, there are a number of bodies which could evaluate. NICE. We have sent a summary of our report, a 29-page summary of our report to NICE. It was acknowledged very courteously, but there was no hint in it that they were going to do anything about the evidence that we presented. And they work to a very slow turnover of studies, and it may be generations before they get around to looking at aspirin, because they're under tremendous pressure from the pharmaceutical industry to look at the profit-making drugs, and aspirin is likely to be well down in the queue. Cancer specialists, well, every oncologist in Wales has been sent a notice about this meeting. I don't know how many have responded, but we've also sent to the cancer committees to do with cancer. We have sent summaries of the evidence that I presented to you. Primary care doctors, well, it's in the evidence is all in the open publications, the easy access papers. Patients in consultation with their doctors, I'm going to come to that later. But why not wait for better evidence? Shall we wait for better evidence? Well, ideally, we should set up a randomized trial in every cancer. Now, there are 200 cancers listed in NHS leaflets, statements. So are we going to wait for 200 randomized controlled trials as each cancer is evaluated? Are our grandchildren or our great-grandchildren going to benefit from this? But to be realistic, we could say wait for some of the new trials in progress to report. And there are new trials. There's a list of trials which are in progress. And you notice there the ABC trial, which has already given a preliminary report, and I've presented that to you. The best known trial there is the first one, the Aspirin trial. Many of our colleagues say, let's wait for the Aspirin trial. That is looking at colon, breast, and prostate cancer, and esophageal cancer. So I would ask, how will that help? It's focused on a few cancers. Poor compliance appears to be increasing and will have to be monitored very, very carefully. And is it fair of us, doctors in research, given the safety of aspirin, should the present evidence on benefit be withheld from patients any longer? Now let me look at that. Patients in consultation with their doctors. The NHS has a clinical ethical guidelines, and they were updated last year. And this states again and again, people have a right to be involved in discussion and make informed decisions about their care. Now, informed decision is a difficult achievement, but I think we have a duty as doctors and as research workers to do all we can to inform the public about the evidence. And the law goes further than that. And in a landmark decision given in the UK Supreme Court in 2015, it stated that if information is material, doctors should generally disclose it. They should not wait for patients to ask. Now, the argument will turn on what is material. Some of you may feel, well, the evidence on this is not material. We need more evidence. But have you the right to judge? Why shouldn't patients be asked? Are you prepared? Aspirin is safe. Are you prepared to take whatever risk there is? We actually tested that in a citizens' jury. Citizens' jury is based on members of the public, and we had 16 members of the public, and we set up what was virtually a law court to ask the evidence, to put the evidence to patients. My health, whose responsibility? For what conditions is the doctor the person who should decide, or in what conditions is the public the right person to decide? The verdicts in that citizens' jury is the preservation of health is ultimately the subject's own responsibility. Information on all health matters should be made easily available to patients. And patients and the public should be more involved in decisions about public health policy. And to that last verdict, the jurors, our 16 jurors, unanimously said it, that the public should be involved even before there's agreement between doctors. A very brilliant oncologist, John Chia, whom I flew out to Singapore to have a talk with him about this whole thing. He points out that if aspirin was properly promoted, there could be benefit to the affluent and the indigent within developed and underdeveloping countries, and there could be a truly global impact on cancer. Can I also put up a slide of the main publications? Now, we have many publications, all in open journals, but there are the three which really summarize, first of all, the safety of aspirin, secondly, the clinical evidence from observational studies, and then the biological mechanisms and the clinical outcomes. And those are all in open access journals.
No more questions, then, Peter. I'd just like to thank you once again for your outstanding presentation this evening.
Thank you.
It's entirely appropriate that you giving this lecture this evening because it was some 20 years ago that you initiated this public lecture series
Yes.
and then pursued it for a number of years after that.
And what a joy it is that it's still going, thanks to you.
Well, not at all. I've served this university for the best part of 30 years, but I worked out today that you have served the university in retirement for that period of time. So that's a remarkable record, the fact that you were a member of staff for 30 years prior to retirement as well. So an amazing achievement.
Well,
And we'd all like to thank you very much for your inspiring presentation this evening. So
thank
thanks
you very much indeed.
Apologies for the few teething problems with our new lecture theatre, but hopefully you have enjoyed being in the new auditorium this evening. We're back on Thursday, the 17th of November, when we have Dr. Neil Stevens from the University of Birmingham, who will be talking on cultured meat, reflections on the sociopolitics of growing meat in vats. So hopefully we'll see many of you again next month. Thank you very much. Dear Marianne. Let's start.
Well, thanks again for coming and being here.
I said to my friend Cara, I said, I had 43 years of that.
Yeah.
Well done, Peter. Excellent job.
Thank
well
you
done.
very much indeed.
Very good. Excellent.
Lovely seeing
As ever.
you. Great.
Very nice to see you again.
Yeah, good. You enjoyed this evening?
I really enjoyed it. Coming again.
Bye-bye.
We'll see you there. Thank you so much. Thank you. You were great today. Thank you.
When everybody was talking, because we had our conference last week, because aren't doctors obliged to go by what is in the guidelines, and we're in a catch-22 with aspirin and cancer, because it's unlicensed, it can't really be talked about, and it's not in the guidelines. So how do we get over that?
So much.
Oh,
Absolutely
lovely,
brilliant.
lovely seeing
Brilliant,
you
brilliant.
again.
Hopefully I'll see you again soon.
Great, great. Lovely memories.
Hey, that was lovely.
Thank you very much
Been
indeed.
meaning to meet you
very much.
forever.
Yeah, it was good.
So he's happy
Yeah.
for
That's
you
an
now.
interesting topic, that, isn't it?
Yeah.
Yes,
So, do you think we'll end up, taking
we're
aspirin
determined that that gets out into the public
Yes,
domain.
I think you're right.
Yeah,
Bruce, my brother's on it.
quite
He was
good.
diagnosed with stage 4 lung cancer in May 2017. He's still taking aspirin every day.
yeah.
He walked into this room, you wouldn't even know he had cancer.
There's suggestive evidence that aspirin is beneficial in that
He's doing a
cancer.
lot of other things, mind. He's doing vitamin D, zinc, NAC,
Yeah.
LDN. He's
Well,
doing everything.
no, I don't blame him.
Yeah.
Yes.
Why
Yeah.
not? Something's working.
Because the loser we really.
Yeah. Well,
Why
every,
gotta
your
go for it.
aspirin?
every blessing.
Yeah, lovely seeing
Great.
you. Thank you so much. Sorry to grab him. Thank you.
Bye-bye.
Time again, Mandy.
Yes.
What are we going to be on then?
Well, I've offered to give a talk on healthy living, healthy lifestyle.
You know, I had a survey sent me today from the Welsh health people, which dealt
Yeah.
with no end of the sort of things you were talking about.
Yeah.
Anyway, I'll let you say goodbye.
Yes, I'll write to you. Yeah.
Would you like Kelly to come with you on your lecture tour to
Oh.
operate your computer?
Yes, thank you very much for your help.
Anyway, see you.
Lovely seeing you.
Lovely seeing you.
Lovely seeing you. Great, great. Look after them.
We hope you look after us.
Well done.
Bye, lovely seeing you. Thank you very